Let's have a conversation with a large eye on what has been happening in the country over the last number of years. Now, we are in November, yes, but there's a month that's set aside to be a month to create awareness on a disease or a condition called sickle cell. And this is September. But let's have it again anyway today. Sickle cell awareness and just getting to understand what sickle cell is all about. We're joined by somebody who understands these things very well, and he's Dr. Nathan Mulure. He is the head of public affairs at Novartis, Sub-Saharan Africa. Dr. welcome to the Situation Room.
Thank you very much for your warm welcome.
It's good to have you. Karibu sana. We normally call that the hot seat.
Yes.
But because you're coming to teach us, we are not going to make it hot.
Yes.
We'll just make it a very comfortable one for you. Let us first of all understand what Novartis is. I just before we went on air, I was saying I know Novartis, but I know Novartis from animal health.
Yes.
From seeing dawa ya ng'ombe, dawa ya kuku, dawa ya mbuzi.
Yes.
But not on human medicine. You have that as well.
Yes, we have that as well. And thank you very much for a very warm welcome. And really glad to be here this morning. My name is Nathan Mulure, as you've said. And I work for Novartis for the last easily 16 years. And Novartis is a pharmaceutical company, a global company based in Switzerland, but with a presence all over the world. I think in about 100 countries now, with about 120,000 employees. So it's a huge multinational that is present in Kenya. In Kenya, we've been around for the last about 20 years, mostly doing work in malaria, but also now expanding to other therapeutic areas. For example, breast cancer, diabetes, hypertension, and the like. Yes, so it's true we have a lot of medicines for human health.
Okay.
That is our biggest pillar today. And we are glad to be in this space of sickle cell disease, which is a big problem in Africa that we want to tackle. And really happy that KTN and the group of Standard Media are doing a great job in creating awareness for this disease. I think with all these efforts that we put together, we can change the tide of sickle cell disease and really see a reversal of what has been happening.
I think we first need to understand what sickle cell is.
Yeah, sickle cell, like the name says, sickle cell. So the red blood cells are shaped like sickle cells. It is a genetic disease that is mostly affecting African population, and the history is pretty long. I think if you look at medical science, dates about a million years back when the sickle cell gene first appeared. And this cell has been protective against malaria. So it was a survival tactic for the human beings during the changes in evolution to survive malaria. And so this cell is genetically transmitted. So the father and the mother must have a trait. And if that happens, then the offsprings would have a sickle cell disease. And what happens in sickle cell disease crisis is that when the red cells are deprived of oxygen, they react and form a sickle shape. So they become like a sickle, like a banana shape. And that affects the cell in terms of deforming itself, because red blood cells, as you know, are easily deformable, but the sickle cells are quite rigid. They don't deform. And when they go into narrow blood vessels, they actually block those blood vessels. And that causes the crisis, the sickle cell disease crisis, which is a painful crisis. And patients endure a lot of excruciating pain. You can't even describe it. They, talk to some patients, they say actually it's like somebody taking a hammer and hammer nails into your bone constantly for hours.
Wow.
It's immense pain. And these patients start getting this crisis from the 9 months of age.
Right.
And it progresses until, the whole lifespan. Yeah, so we think that with a lot of effort, advocacy, with a lot of awareness creation, we can make a dent on sickle cell disease.
In terms of prevalence, Dr. what are we looking at? And I'll talk about in Kenya for now, because in West Africa, the prevalence of sickle cell is extremely high. We're looking at countries like Nigeria, Cote d'Ivoire, Ghana, very high, especially in certain parts of the country. And even as you're talking about it, hereditary, have you been able to point to environmental factors or triggers that play a part then in the high cases that you see in some parts? And then moving to the eastern side of the continent, looking at raising awareness, how potent is the prevalence then of sickle cell in Kenya?
Yeah, that's a good question. And unfortunately, we have paucity of data. There's no data on sickle cell disease. And even as we speak today, we don't clearly know how many, cases are produced every year. The estimates, so to speak, I think in Kenya they talk about 11,000 cases every year. In West Africa, as you say, it is quite prevalent, mostly in Nigeria. I think 2% of population in Nigeria have the trait. 2%. In a country of 200 million people, you take 2%, you're usually talking about 2 million patients every year. So it's a huge problem. Also in Congo, DRC, another huge problem. And really it's just genetic, not environmental. It's purely genetic. It's transmitted through, families. And that in itself, and based on our culture in Africa, we like, even intermarrying within our communities.
Right.
We actually advise that marry within your community because that is where the cultural norms fit best. People are comfortable because your wife can speak your mother tongue. The cultures are similar, so it's easy to integrate. Unfortunately, if that community has a sickle cell trait, then that is propagated in that family or community. That's why you see in Western Kenya, for example, the Luya and the Luo, go to Homa Bay district, go to Kisumu. It is quite prevalent. And then go to coastal province in Taita Taveta. Again, because people marry within their communities.
Can you break that down a little
Yes.
bit? Because, again, going back to Nigeria, the conversation before people get married, interestingly enough, is have you checked your genotype?
Yes.
Before now, you marry somebody who, and I often get confused, AS, SS,
yes.
go and check so that you're not then, getting married and then having children who would be sicklers.
Yes.
What is that science all about? And what do you watch out for? How do you know that you're carrying the gene? Somebody is carrying the one that if you combine them, then you're guaranteed to have a healthy child or not.
Yeah, so the sickle cell trait basically occurs in many communities in Africa. So for one to get the sickle cell disease itself, both parents have to be carriers. So if the mother is carrying the gene and the father is carrying the gene as well, there's a chance that one of the children will also be carrying the gene or have the disease itself. So the trait itself is called the SS. So when you have SS, basically you have sickle cell disease. If you have AS, then you don't have the sickle cell disease. But SS really you have the sickle cell disease. So when you have the sickle cell disease, then you manifest those signs very early in life. Even from the 9 months of age, you start having crisis as soon as the fetal hemoglobin goes down. Then the SS takes up, and then you start having those crises because the SS cannot respond to stresses of oxygen. The cell becomes a sickle cell shape. So in Africa, of course, you're always asked to do a background check in the community and check if they're your relatives, check if you're related, and if you are, then you're advised not to. But again, this cell has now become prevalent in many people, and the only way to know is, of course, to do the test. So it's a rapid diagnostic test. So you just have your blood pricked, and they can tell you whether it's SS or whether it's AS. And based on that, then that knowledge informs you of what to do in terms of getting married. You can seek genetic counseling. It's difficult to be so prescriptive that you tell couples by force ABCD. It's quite difficult because these love affairs are quite emotional.
Yeah.
But it's important that parents are informed, that they have full knowledge, that as they make that decision, they know the consequences, they know how to even take care of the children as soon as they're born, take them for a test. Luckily, some might not have the trait at all, or this SS. Those that have, again, start treatment very early. We've known that if you start treatment early as 9 months, then the patient can actually lead a normal life, devoid of crisis. And we've seen patients who are now in their 16 years old, teenagers. They've never had a crisis because they've been taken care of right from the beginning. And so we want to propagate that message that if you know your status, if you know the child is carrying a trait, if you know the child has SS, then start treatment very early.
So it's about treatment. And treatment is like managing the situation. There's no cure for sickle cell.
Well, as we speak today, there's no cure. But there are advanced centers in the world that offer bone marrow transplant. So you can have your bone marrow, transplanted, and then you sort of get cured. That's very costly, and it's a very complicated process. And we don't have that in Kenya. I think in Africa, Nigeria has just started a transplant, and probably South Africa. But in many countries, we don't have. And then, of course, there's the gene therapy that could be a definitive cure. Gene therapy, I think we are still 10 years to go before the gene therapy starts. What happens in the meantime? Today, how do we handle the situation today? Yes, there is no cure as we speak today, as in definitive cure, apart from bone marrow and then gene transplant. However, there's a lot we can do to let these patients lead a normal life.
Tell us about the patient, Dr.
Yeah.
How does a patient live their life? I mean, what does a patient who has sickle cell, what do they go through in their life on a daily basis? For those who don't know, have never come across somebody with sickle cell.
Yes, that's a good question, and I'm happy that you asked it, because there's a lot of ignorance about sickle cell disease amongst patients, amongst healthcare workers, amongst caregivers. And these patients who are born of sickle cell disease, they endure a lot of suffering. And right from the time they're born, you find that they fail to thrive. For example, they don't grow as usual normal babies grow. They're delayed, so to speak. And when they have the crisis, like I said before, the crisis is a very painful crisis. It's acute pain, and it's so distressing to the child. It's distressing to the caregiver. And this crisis doesn't give you a warning when it comes. It could come at midnight. And it's painful and, almost paralyzing pain. So what do you do in a small hut in Kisumu at midnight when this pain has just struck? What do you do?
Painkiller.
You can't even go out. I mean, the roads are dark, the clinics are closed. The mother has to endure that pain with the child until morning. Then in the morning, go to hospital. In the hospital, and you'll get medication, get stabilized. But again, you find that these patients go to clinics so often until their peer sort of burdensome to the healthcare providers, and they sometimes endure a lot of stigmatization as well in that setup. So what we're telling people now is that we need to understand this child's pain and condition.
So what happens? So just the child is okay, and then suddenly they go into a fit of pain. So they have basically just crying and wailing, and they are in pain.
Yeah.
And is it for a period of time? Is it for a short period, for 30 minutes, 40 minutes?
The pain can last very long.
What is very long?
It can last days. I mean, I had a friend who could be in crisis for hours and then go into crisis and be in crisis for 3 days. So you can imagine 3 days of that constant pain, and they would not be, they would not come out. They would have to be indoors, and it's writhing in pain that very few painkillers would be able to sort out. Exactly. And then maybe this is also something you can talk about then, because they would be on these painkillers constantly, and then that also posed another health hazard to them, because there was no option apart from getting rid of the pain and managing the situation at that time.
Exactly. Yeah. So the crisis can actually last a long time. It can last even 8 hours. And if the patient is not getting relief from that crisis, that immense suffering actually causes psychological distress to the patient.
Yeah.
And also you find that because of these frequent episodes of pain, sometimes they go to the healthcare workers and they're told, you guys want to become drug addicts. You're just used to painkillers all the time, and they deny that painkiller. The healthcare workers need to understand that pain is real pain, and not just patients malingering to pretend that they have pain and for the sake of getting medication. The painkillers that they get, of course, you can get paracetamol, but some also actually require stronger painkillers, like morphine, for example. Are those drugs available in all the health centers? Probably not. So they end up with a lot of pain, and what you need to realize that pain is not just pain. It's a crisis. We call it Vasoclusive Crisis, where the blood vessels are blocked, and this can lead to stroke in a child. A child getting stroke because of the pain. It can lead to organ damage, kidneys, the eyes. You block vessels that supply these organs with oxygen. They get organ damage, and that's why you find that in Africa, sickle cell patients don't live for long.
Right.
I mean, they live for 30 years, 20 years. We don't see patients living to 80 years like in the US because of that, lack of intense care that those countries have. So we want to change all that tide. I mean, it's a long journey, but I'm really grateful to the Ministry of Health. The MOH has come in very strongly to support the sickle cell program and even launch the guidelines.
Even as I'm hearing you say this, and
Yeah.
awareness that is being created for patients
Yes.
and their families, it seems to me that there also needs to be awareness that then spreads to health workers for them to understand. Because at that point, with a crisis, for example, what are you trying to do is manage the pain. If there's no cure for this, treatment that can be given on a regular basis doesn't necessarily stop a crisis. So in terms of then awareness that is now being built or created, what's the target then for healthcare workers, apart from a doctor, for example, who understands what is going on here, and those who may need to administer medication or who receives the patient on a regular basis? What do they need to be clear about their understanding?
Yeah, so again, a very good question for healthcare providers. I think what we have done, first of all, is to support the Ministry of Health to come up with guidelines for treatment of sickle cell disease. That was lacking for the longest time. So since 2014, when the first guidelines were discussed and mooted, they sort of stalled for about 7 years. So we did work with the Ministry of Health last year and Capricorn. Capricorn is a Kenya Pediatric Research Consortium. And Professor Were, which did a very commendable job in setting those guidelines. Within 6 months, guidelines were ready. And the same were launched this year in June. So that's the first step, that we need to have guidelines, because guidelines really have the prescriptive pathway to follow in case a child gets a sickle cell disease. The guidelines specify which medications have to be kept at which health center, for example. They specify the psychosocial support that the patient needs, and the caregivers as well. We forget the caregivers sometimes. The caregivers are also patients.
Yeah.
They undergo a lot of suffering. They have that sympathetic sort of suffering with the child, and they also need to be taken care of. So the guidelines were the first step. Right now, we're working with the Ministry of Health to ensure that these guidelines are rolled out to the whole country. We want to work with the counties. Counties are going to be very, very critical in making sure that those guidelines are established within their precincts. And, the guidelines are quite, I've seen one of the best guidelines that we've ever seen in sickle cell disease, are the Kenyan guidelines, and they're quite detailed. So we hope that by training healthcare providers, by rolling those guidelines out, a lot of difference will be put in place. Yeah.
This is the Situation Room. In the room this morning is Eric Latif and Ndu Oko. And our guest is Dr. Nathan Mulure. He's the head of public affairs at Novartis, Sub-Saharan Africa. We are talking about sickle cell awareness. And Doc, of all the things that you've told us, let's look at the country, Kenya. Are there some parts of the country where sickle cell is more prevalent than others?
Yes, definitely. There are parts of country that are quite afflicted by sickle cell disease. This is in Western Kenya, and also Nyanza province, and down to the coast, Kwale area, Taita Taveta area as well. Quite high incidence of sickle cell disease.
Is there any reason?
Yes, the reason actually is that, first of all, like we said, people marry within the communities. So if the trait is there, then you find that it continues getting propagated within those communities. The second reason is that the sickle cell itself seemed to be protective against getting malaria. It was a survival technique for the human being. Those who have the sickle cell trait and disease then don't get afflicted by malaria. So they tend to survive in malarious regions, and which is Western Kenya, and also in the coastal province. So it was a survival technique by the cell. Unfortunately, the consequences are also quite severe in terms of getting the disease itself. Yeah.
So not everybody who has a sickle cell gets sick.
Exactly. Yes, the people who have the trait. In the human red blood cell, we can call it, HbAA. That's a normal human red blood cell. The carrier is HbAs. So the S is the carrier. The sickle cell patient is HbSS. So you have SS, you have the sickle cell disease. When you have AS, you have the trait.
Okay.
So if your mother had AS and your father has AS, there's a 25% chance that there'll be an SS in that family.
Okay.
Hence, you find
amongst any of the children.
amongst any of the children, yeah,
Okay.
25% chance. They can be lucky sometimes that all the kids don't have the disease at all, but definitely there are those who will be carriers in that family. So, unfortunately, some end up with SS, which is a sickle cell disease, and then suffer the consequences throughout their lives. Yeah.
So there are many people who basically have the AS and they
Yes.
don't know. They marry somebody who has the AS, they don't know.
Definitely.
And there's a chance that their child could have the SS.
If both parents are carriers.
Yes.
Yes, definitely. There's a chance of 25% that one of the children will have the disease itself.
Okay. And then nobody else maybe has ever had the disease. So there will be that whole issue among the community of why is this child crying all the time? I mean, why is this child different from the other children? Why is this child different from the other children in the village?
Exactly.
Now, how much, having interacted with all these communities, how much awareness is there in the communities, especially in these areas where you're saying have high prevalence?
Yes, it is still low awareness. It's very low. And you find that sometimes in families, there are those families where the babies are dying at a very early age, 5 years, and people start looking at that family and say, that family, there must be something wrong with that family. Maybe that lady was bewitched along the line.
Yeah.
Maybe there's a neighbor who looked at them with bad eyes. Why are the kids dying? Before 5 years dead. This could be sickle cell disease, and unless the doctor has that clinical acumen to suspect that this could be a sickle cell disease case, they don't even test. We've seen patients who have been treated day in, day out for pneumonia, for malaria. They're always sick. They're always in hospital. So it's routine, antibiotics, routine antimalarials. Nobody wants to check about the sickle cell disease. So we need to really sensitize healthcare providers that they need to have a clinical index of suspicion to test for that. And those that get tested early and put on treatment, they have fewer crises. They basically live sort of a normal life. And that's where we want to go, to really increase awareness. Awareness in the community also is very, very low. Stigmatization is rife. People who are always sick, people look at them differently. This child is always sickly. The sickle cell patients also don't thrive in terms of weight. They find an adult patient, weighing in their 30s, in their 40 kilograms. So they're deprived of that weight. They look different. They, physically as well, because of the many insults that they've gotten in the crisis. Yeah.
So then we're looking at a clearly poorer quality of life.
Yeah.
But from what you're saying, if detected early enough, and you're talking about by the time they're still infants, detected early enough, then there can be an improvement on the quality of life that they would otherwise experience?
Definitely, if they are detected early. And that's what we're now proposing to the government of Kenya. We need to put in place newborn screening. Universal newborn screening. I know it's an expensive, costly affair, but it's worth the money, because if you have that newborn universal screening, then when babies are born in the maternity, within, they're tested for sickle cell, and most of those highly prevalent counties,
Right.
Can actually target those counties, so that all babies who are born are detected early, and if they're detected to have sickle cell disease, then we also have what we call reverse cascade training, testing. The siblings of that child, the near relatives of that child, can also be tested. And if they're found out to have the sickle cell trait, then they have that knowledge that they have the trait.
Right.
And even as they progress in life, they have that in mind.
Okay.
So universal newborn screening would really change the tide against sickle cell disease.
I have to ask, this treatment, obviously, what does it do? Because you're dealing with a situation where the red blood cell is already shaped. Save for the therapy that you talk about, going in and changing the shape of the cell, right?
Yeah.
So that oxygen can then, be delivered. I'm interested to know exactly what this treatment then does. Because you have pain management, which is a different kind of treatment. But what does a sickle cell treatment that's available now, what does it do for the patient?
Yeah, so the sickle cell drug that we have today and how it works is that it improves the hemoglobin F. We also have the hemoglobin F, which is the fetal hemoglobin. When babies are born, when they're still young, they have the fetal hemoglobin, which is sort of protective against the crisis. So this drug basically improves the production of that hemoglobin F, so that it is in higher quantities. Even as a child grows, it's still available in higher quantities, and that prevents the crisis by even 50%. You're talking about if a child has a reduction of crisis by 50%, that improves the quality of life tremendously. Because that crisis really is what destroys the patient's organs. It destroys causing stroke, and resultant effect is that the patient has a very short life. We've seen documentaries of patients. I recall a boy who was saying, living in the estate, and he was saying that all his friends keep on asking him, "Hey, you're still alive?" Because it was a very depressing video that was on YouTube, and so he's being challenged because they expect him to not to live for so long. So whenever they see him, "Oh, you're still alive, you're still alive." But this guy was a very strong boy and very motivated.
He's fighting.
Yes, he was fighting. And I think if these kids can get education on how to avoid the crisis, because they can actually tell when they play football for a long time and they don't drink water, the mamas will tell them, "Please drink water." Those that don't drink water, you find that actually end up with a crisis. So yes, they have played for long, they have enjoyed their day, but at night, there's a crisis. During cold weather, in June, July, August, again, many know that if they expose themselves to cold, they get a crisis. They have learned to keep themselves warm, they don't go out, and they pass through that period without a crisis. Exam period in school is another one, where when kids get stressed, just that stress itself can trigger a crisis. And unfortunately, when teachers don't understand this, they always think that this child is avoiding exams, So they, under so much pressure, they about to do exams, they're in hospital for 2 weeks. When they come out, exams are over. And it's quite a challenging period for children as well. So teachers need to understand that these children are special children. They need special care. They need to be treated in a special way to enable them to progress in life. And yeah, in countries where this is quite advanced, sickle cell patients have become doctors, they become MPs, and they can lead a normal life if that is allowed.
So it seems as if the awareness then needs to spread across sector, beyond, the medical sector. Because now we're talking about teachers, students in school who've missed 3 weeks of school at one go. And then there's not understanding if a situation of stress arises, the likelihood of getting into pre-crisis, gets higher. So it looks as though many more than within the medical fraternity need to have this awareness, need to be aware of what is going on.
You said it right. We need to go beyond the healthcare system. Education, there's a lot of work to be done in education. In the churches, in the communities, a lot needs to be done also, because when people associate sickle cell disease with witchcraft, again, there's a lot of ignorance about that. Families need to understand how to take care of these patients, because those that understand, you find that their patients in their family entourage can lead a normal life, because avoid the crisis simply means if I have no crisis now, if I'm a patient and I have no crisis, I'm leading a normal life. If I can postpone that crisis for as long as possible and even avert it, then I'm living a normal life. That needs to be inculcated, that we can actually achieve that kind of status.
I'm curious, why is it called crisis? Why not episode, attack, or others that we see being used in the medical field?
Yes, it is called a crisis because it's a crisis. And if you go to the medical realms, it's Vasoclusive Crisis. Vasoclusive simply means the vessels have been plugged. When you plug a blood vessel, you deprive that organ of oxygen. If it's a kidney, for example, if it's the heart, if it's the brain, that area dies, literally dies. And the consequences, if that happens many times, the mortality goes up. Patients, live to their 20s, 30s. They've had so much damage that at the time they are in their 30s, they're basically having a very short lifespan. So if we avoid those crises through treatment, through proper care, through reduction of stigma, because stigma is a very big barrier to treatment. We've seen patients who, when they go to hospital and they're not treated well, they're even told they are becoming drug addicts.
They won't come back.
They won't come back. They actually manage that crisis in their own home environment. And that pain is endured, and that suffering is endured until they're out of it.
And the damage to the organs.
And the damage to the organs.
Every time the crisis then occurs.
Exactly. And that adds to the mortality increase in this category of patients.
With the issue of now getting healthcare, does insurance cover sickle cell? Because we see many insurance covers will talk about, pre-existing conditions and all this and the other, and there are things that they don't cover. Do many insurance providers in the country cover sickle cell?
Yes. So, for example, and that's a very good question that you've asked about insurance cover and all this story about pre-existing illness. Some don't cover, of course. And NHIF, for example, only covers when the patient is admitted at hospital. We're trying to talk to the NHIF today, and even model that if they are able to cover for this treatment that's available, that is quite cost effective and reduce the chance of admission to hospital by 50%, then the country has saved money. Because when a child goes to hospital for 2 weeks, there's blood transfusion, there's a bed space, there's the caregiver also who accompanies the child. If you look at the cost per year, it could easily be 100, 200K that the patient actually has to get from NHIF. And if the patient also goes into kidney damage and is transplanted, another cost. If we can avoid all these disasters from happening, the cost savings is huge. So we're actually talking to NHIF now and see if they can cover for that drug, outpatient cover. That would be a game changer.
And what is the average cost of now the treatment?
Well, it varies, I think, depending on the weight of the patient per milligram, kilogram body weight. I could say perhaps, maybe $20 for a month of treatment.
So 2,000 bob a month.
Yeah.
That's also pretty high.
It's high, and not forgetting that also they need anti-malarials, prophylaxis. They need to be put on folic acid. They need vaccines for prevention of pneumonia and the like. So
combined.
Yes, combined.
The entire therapy then is coming to what, 5,000 thereabouts?
It could be easily 5K. Yeah.
Every month.
Yeah.
This is pretty high.
It is high, but if you look at if you avoid all those costs, admission to hospital for 2 weeks, 3 times a year, you're talking about easily $500,000 in terms of total costs. So I still think that if we put these patients on treatment and they're vaccinated against infections, they're put on a drug that can help build up the hemoglobin F, the cost-benefit analysis is still higher when you give these children treatment.
In terms of numbers, just basically average numbers, what kind of numbers are we talking about in the country in terms of patients who have sickle cell disease in Kenya?
Yeah, that number is not known as we speak today. There's lack of data. There have been estimates talking about 100K, 200K, but really nobody has the right answer. I think this time the Ministry of Health is trying to build up a database with all these activities that also KTN is supporting. That database will now start helping us to know the number of people living with sickle cell disease in the country. In terms of the newborns who have the sickle cell disease, I think the estimates say 6,000 per year are born of the disease in Kenya. In Uganda, it's much higher, at about 11,000. So with those kind of numbers now we can start aggregating to have a semblance of what the numbers really are. But to point a finger on a certain number, right now, nobody can do that because there's no data.
Right. In the medical fraternity, I mean, more recently than not, the focus is now being geared towards preventative care as opposed to curative care. Now, when we're looking at sickle cell, clearly, as you've mentioned, one of the tenets that you'll be looking at is curative in the sense that you want to then advise people to know their state in terms of sickle cell, in terms of the gene that they may be carrying. To me, that looks like a radical form of preventative care, but absolutely necessary when it comes to this, because that is one way you can be guaranteed of making sure that your offspring, that you're not adding to the numbers of those who have sickle cell. So what kind of attention then in this awareness then would be pegged on that kind of preventative care, really making sure that communities, families, units understand what essentially could happen if you're paired with somebody who is a carrier as well?
Yeah, that calls for education in the community. And by doing all these activities and talking about sickle cell disease, even on TV right now, that adds to the body of knowledge for the sickle cell disease community. So it's really, really important to know your status, know your genotype. We've had campaigns, for example, in Ghana, where we rallied people to know their status, know their genotype. And it's a one-off test. That's the beauty about sickle cell disease. That it's like a blood group. Once you have blood group
Once you know you're O, you'll be O for the rest of your life.
Exactly. Yeah. So we want to encourage people to really know their status. As you do your blood group, can also do a sickle cell test. Know that status. Keep it in your heart. Know it. If it's AA, for example, when you have no carrier at all, then it's fine. But if you're a carrier, then you need to be very careful as you progress in life. And we can't be prescriptive as healthcare workers or companies to force people to go and have it tested. No.
So you say it's a pretty straightforward test. So I walk into any health facility and I say I just want to know my status.
10 minutes, you have your status. Yeah.
Right.
Rapid diagnostic test. Yeah.
Would you suggest it for children? And I say this as parents taking their children, who clearly maybe normal, but possibility of you being a carrier, whether it's you've had an incident in your family or not. Would you suggest that for children now so that they grow up knowing what their status is?
Yes, I think any time you have an opportunity to have that test done, I think best is to do it. Because it's a one-off test, and that test is valid the rest of your life. It will never change. So the earlier you know the test status, the better.
How much does it cost?
I wouldn't put a finger on the cost, but I think from what we have done in terms of market research, I think $5 or less, about 500 shillings. Yeah, that would give you the test. Yeah.
Okay. Doc, everything that we've said today basically is just pointing down towards a need for increased awareness of sickle cell. For people just to understand what sickle cell is, for people to know how to tell when somebody is in a crisis and what they need to do. For example, like we're saying, the caregivers, what do you need to look out for? What do you need to do if a child under your care goes into an attack? Or if you're in a school environment, your classmates, you need to understand what they have. Have there been any efforts towards creating this awareness, outside of, just the awareness month, in terms of campaigns and roadshows into schools, into communities, into churches, like you said, chiefs, barazas and all? Anything like that? No?
Yes, a lot has been done. But what I can say is that when a child has a crisis, the best place to take the child is a hospital. It's a medical emergency and has to be treated as such. I wouldn't tell people in schools now to start putting painkillers in their closets and all that. No. Best place is to go to the hospital. The guidelines are very explicit on what to be done. The caregivers know what to do in terms of alleviating that crisis. Could be fluid rehydration, could be painkillers and injectables. So all that needs to be taken care of in the environment, in the confines of the hospital. However, there are many, many ways of knowing that one can get a crisis. And people who have lived with sickle cell disease for a long time know that if they do certain things, they're going to get a crisis. And sure enough, when they do them, they get a crisis. We've seen patients who, whenever they go for swimming, they know they get a crisis. So they avoid swimming. Those that play football for long hours, they know that they get a crisis in the evening. So they avoid those long exposure and long stresses. So, and also the applications now available, medical applications, where you can actually key in your data, and the app can predict the crisis and also alert you to avoid certain situations. So there's a lot of stuff that can actually be put in place, employed to avoid a crisis. I think for us, what would be really critical is to ensure that patients are living a crisis-free life. That greatly improves the quality of life for that patient. And there are many things that can be done to increase that knowledge on how to avoid a crisis. And in the event that the crisis happens, then what is to be done? Rush to hospital, hoping that the healthcare providers in that scenario will be able to take care of this patient quickly. Because patients go there as an emergency, but they're told to wait for even 3 hours before they're attended to.
Yeah.
This is an emergency, and the healthcare workers need to have that keen eye that it's an emergency. Let the cough and cold wait. And let me sort out this patient who has a crisis. Because if that doesn't happen, next time they have a crisis, they'll stay at home. And that leads to organ damage, leads to vasoclusive, can lead to stroke, and many things. So let us have that very keen acumen as clinical healthcare providers to treat that as an emergency, because it is an emergency.
We've seen the disappearance of few diseases around the world. And vaccination drives sometimes have led to then the disappearance of certain diseases. Polio in some countries, we had things like, typhoid that disappeared in other countries. Is this one of those diseases that you can say, even though there's no cure today, that with this awareness that's being built up, with the recommendations that you give to individuals, knowing their status, that we can actually see a time in the future when this too can be eradicated because now people are making conscious efforts about who they procreate with, essentially.
That is very well said. I think sickle cell disease, and I also always add cervical cancer. Those are two diseases that can actually be, made into rare diseases. Right now they're common, but if we have an action plan, even say Vision 2050, and the government puts in place all the efforts to make this disease a rare disease, it is possible to make it a very rare disease. And the bit about that, when it's a rare disease, there are a lot of resources to take care of those patients. When it's common and there's a crisis, then it becomes very burdensome for the healthcare ecosystem. So yes, the answer is yes, we can actually make this a very rare disease if we have an action plan and follow through that action plan, and in the next 30 or 40 years, really reduce the number of patients who are born with the sickle cell disease. But it requires a lot of concerted efforts.
Right.
Yeah.
It requires a lot of concerted effort and leadership.
Leadership. Yeah.
Have you seen any semblance of that, of conversations that are now taking place in the healthcare system, in the sector, saying, let's start talking about this and how we can actualize it?
Yes, I've seen that. Starting with the Ministry of Health, there's now a strong department that is taking care of sickle cell disease, NCD department in the MOH, which has done a lot and a tremendous job. Creating awareness, of course, and also availing the medication for sickle cell disease in hospitals, putting in place the guidelines. Those are major steps that were inexistent a few years back, and it's really the beginning of a journey that can actually change the tide of sickle cell disease in the country.
Dr. Arif, thank you very much for coming this morning.
Thank you,
and
my pleasure.
shedding all this light on sickle cell. There are very many people who I'm sure did not know much about sickle cell, who know now something about sickle cell. And if we continue these conversations, then we can get to that point where we all know about sickle cell, then we can all together walk towards that journey of making it a rare disease.
It should be a
in
rare
this
disease
country.
and very rare.
Very rare disease.
Yes.
Dr. Nathan Mulure is the head of public affairs at Novartis Sub-Saharan Africa. He's been with us talking about sickle cell awareness, and we've been live on KTN Home, on SpiceFM and online.
This is the Situation Room, the only way to start your day.